morning, everyone. Thank you, Dr. Veena, for the invitation. So, perimetry is a very subjective test based on, again, it depends upon the patient's responses. So you can get a lot of errors due to the vagaries of the patient and the patient's responses. But errors can also occur due to, mistakes that you make in the setup of the test. So I'll just take you through a few of these errors that we see in practice. So this was a 69-year-old male who was referred for worsening glaucoma. You can see the total deviation. It shows a typical glaucomatous arcuate defect. So we did a repeat test in our clinic. So, and you can see the total deviation is much better in the second test. Though the partial deviation looks the pattern deviation looks almost the same. But you can see the mean deviation has improved from -6 to around -1. So we did, we had to go back looking what was wrong, and then we found that the age that was entered was wrong in the earlier field that was done elsewhere, where it was 24 years, though the patient was actually 69 years. So it's very important that the actual date of birth is entered. Because it is the total interpretation of the test is based on comparison with age match normal. So if you get the date of birth wrong, then you are comparing here, it was compared with a much younger patient with better retinal sensitivity. So you will have a worsening of the field that shows in the printout. So the pupil size is very important. So if it is a very small pupil, make it a point to dilate the pupil. If it is less than 2.5 millimeters, it's a good idea to dilate the pupil and then do the test, and always record the pupil size so that on subsequent visits you have a consistent pupil size. So this was earlier a defect that we used to have when we had a lot of patients on pilocarpine. So it also, when you have a small pupil, you also have a reduction in the retinal sensitivities due to the reduced amount of light entering the eye. So this was a 27-year-old myope on regular follow-up for ocular hypertension with normal cup disc ratio. She always had normal fields until one day she appeared with she presented with a field defect like this. You can see some early paracentral field defects which didn't match the cup disc ratio at all. So we had to do some investigative work, we had to do some detective work before she spilled the beans. And she told us that she had undergone LASIK a year back, which she forgot to tell us. So we had done the test with a -4 diopter sphere, and then on repeating the test with no refractive error, with no refractive correction, we found that the field had improved much. It had become normal, and the mean deviation had also improved. So it's a very good idea to do a refraction on the day of the perimetry test, so that you don't get such surprises. So if your refractive error that you add, the refraction is wrong, that also reduces the brightness of the stimulus on the retina, and so you can get false values. So which strategy to use, either a Sita standard or a Sita fast, depends on what was done earlier. So don't switch from a Sita standard to a Sita fast, because if you do that, often you see that there will be an improvement in the field, which is not actually the improvement in the disease condition. So what field to use also depends on what was done earlier. You can either do a 24-2 or 30-2, but in advanced field defects, there's no point in wasting time doing a 24-2 again. Go for a 10-2. Also nowadays we do 10-2 as a routine to pick up early paracentral defects. But if you have a 24-2C, there is a newer programs that have come, then you can do that, which the 24-2C has got 10 additional points that are tested in the central field. So that also you can do. Stimulus size, usually size 3, and you stick to the same stimulus size, don't change it. But changing to a larger size, a size 5, is good in advanced cases. You can try in advanced cases. You can see the monitoring is better if you use a larger stimulus size. Also, if you see a lot of patients who seem never to be able to get a good field done. Okay, in such patients, it's a good idea to change to a size 5 and see if they can get a good test done. So if you see a field defect that does not correspond to any typical glaucomatous field defect, think of artifacts. Now this is a rim artifact where the lens holder was placed too far away from the patient's eye, and we see these more commonly with high plus lenses. And also if you don't use the wide aperture lenses and use the rimmed lenses, then you get this defect. And also if you use two lenses, more than a lens, one lens in the holder, you can get these defects. So we have all been taught not to look at the grayscale much, but looking at the grayscale is very good to pick up artifacts like this. So this may look like some atypical glaucomatous field effect, but it could also be due to a ptosis, a lid ptosis, or a dermatochalasis, or a brotosis. That is also quite commonly seen. So lid and bro artifacts, if you think it could be due to them, you can just take the upper lid and do the test again, or patch the bro up, and then the artifact disappears. So this was a field defect that was increasingly being seen the last couple of years when we used to do the test with the mask on. So it's either due to the mask or due to the the breath fogging the lens, or sometimes the mask is put so tight that the tissues beneath the lower lid, they are bunched up, and they can cause a field effect like this. So this we can call a mask scotoma. You can get a similar defect if the forehead is away, away from the bar, the forehead bar there, and a defect in the superior field if the chin is away. So a constant monitoring of the position is very important during the test. So look at this field. So it looks like a typical dense dense field defect in the superior field, almost like an altitudinal defect. But what is surprising is that it has crossed the horizontal meridian. And you can see the other eye, the fixation has also shifted down. Okay. So what is this due to? It is due to some error in the fixation target. So you all know when we do the foveal threshold, the patient has to look at the four small targets there and the center of the four targets. And after the foveal threshold is done, the patient has to shift to look at the central fixation target. So sometimes the patient doesn't realize that he has to look at the other one. You have not, either you have not told him properly or he doesn't understand. And then you get a field effect like this. So once that is corrected, you can see now it is shifted up. The blind spot is also shifted up in the other eye. So it's very important that you make sure the patient understands what you are telling him. You all know of the clover leaf pattern, where in an inattentive patient or an exhausted patient, fatigue patient who is fed up of this computer game that he is playing, and then you can see the the first 4 points, the 4 areas that are tested are those central ones which the patient responded to in the beginning, and then he loses attention, and you have the clover leaf pattern with significantly high false negative values. You have an inverse clover leaf pattern when the patient realizes late that the test has started. So he misses those initial points that are tested in the 4 quadrants, and then he starts responding, and then you get a field defect like this. So when you see a field defect like this, where you have a normal total deviation and an abnormal pattern deviation, don't jump to a conclusion that it's glaucomatous, because if it is glaucomatous, you should have a corresponding defect in the total deviation also. So when you have a defect like this where only the pattern deviation shows depressed spots, think of a trigger happy patient. So you look at this field, you can see a high false positives, fixation losses, you have superhuman retinal sensitivities. The maximum that you're expecting in a young adult is around 40 decibels in the center. And as you move away towards the periphery, the sensitivity should reduce. But you can see here values like, you have 49 and 50 in the periphery, which is a superhuman value. Also, you can see the white scotomata in the grayscale, and the GHT is showing abnormally high sensitivities. And you see the pattern deviation, which shows a lot of depressed effects, whereas the total deviation looks almost normal. So this is because the way the pattern deviation is tested. In pattern deviation, you are looking at the 7th most sensitive point. Now here the most sensitive point is very high, it's got a very high sensitivity, and as a result there may be a few points which were a bit normal or lesser, and that will appear as defects. Single abnormal field, okay, always repeat, because there is a significant learning curve to this test that is done. You may have to repeat the field several times for some patients until you get a good reliable field. So also you look at the disc findings. If your disc findings are not matching with the field findings, you have to repeat the test. So you can get surprises. Be prepared for surprises in perimetry. So this was a young optometry student. She was so happy to get a field, and she came to me showing her field. So I was surprised to look at the fixation loss, the 17 by 17. So that's 100% fixation loss. And there was something MS. So you can see it was the right eye that was tested, but there's no blind spot there. So, went and talked to the optometry student and her friend who had done the test, and we found that they had forgotten to occlude one eye. So you can have surprises like this, like the right eye is entered, but the left eye is tested. Okay. So those extra minutes that you spend talking to the patient are well spent. Okay, talk to the patient, tell the patient that it's not a big major examination that he is going to go under. Going to be tested for. So you can tell the patient to blink, to take frequent breaks. You can just press on the button and that will pause the test. Take frequent breaks, okay? And also if you see that the patient is not doing the test properly, you take a break, explain again. So those minutes, extra minutes that you spent are well spent. Also, it's a good idea to occasionally sneak on your optometrist, because you have to make sure that they're doing everything correctly. Sometimes they just start the test and then they don't monitor. That is very important. You have to constantly monitor the test. So it is very important to occasionally train your optometrist, and see what they are actually doing. So we come to the age-old teaching again, to never interpret a field in isolation, always correlate clinically. So if your disc findings do not match the field changes do not match the disc findings, go back and look for something else that could be the cause for the field effect. Look for masquerading, either optic nerve lesions or any retinal lesions. Look for artifacts. Think of artifacts if you see some defect that is not corresponding to a typical glaucomatous field effect. Also look, compare both fields together. Sometimes when you see both fields together, you'll realize that this could probably be a neurological field and not a glaucomatous field. Thank you for